is intravascular. Now, I sat there last night, and this was after 9 o'clock, and I sat there and said, okay, if 5% of extracellular fluid is intravascular, that's 5%. Okay, so if you weigh 200 pounds, 5% of that's going to be 10 pounds. Water weighs 8.34 pounds a gallon. So how many gallons of fluid do you have intravascularly? So it is, and then blood is measured in pints. So how many pints is that? And hemoglobin is measured in grams per deciliter. So if we've got the hematocrit of 43 that I showed you yesterday, and you in 43, so hemoglobin is really 1/3 the hematocrit. I haven't told you that yet, but so if your hematocrit is 45, your hemoglobin that measures is going to be 15 grams per deciliter. How many deciliters in a pint? How many pints in a gallon? How many gallons in a 200-pound guy? I mean, some of the crap that goes through my mind.
Is this in the test?
Okay. Well, I never figured it out. I was sitting there eating macaroni and cheese and there you go. So it says right here, water may be lost or shifted between any of the two compartments. What two compartments are you talking about? Are you talking about the extracellular, intracellular? Or are you talking about the intravascular, extracellular? It's this part right here. Intracellular and extracellular. Fluid status. It's an important thing to know and recognize in patients. Body weight is the best measure or best way to determine a patient's fluid status. If you have a patient coming in complaining of shortness of breath and a 40-pound weight gain over the past 2 weeks, that 40 pounds was not fat, it's fluid. And as I mentioned earlier, water weighs over 8 pounds a gallon. That's a lot of fluid. If you admitted somebody to the hospital and you are running fluids in them, and you are measuring their urinary output, you're measuring what's going in and what's coming out. That's ins and outs. This is an important thing to keep up with if you have somebody admitted because of renal failure or congestive heart failure, where they're in fluid overload. If they're gaining weight, you need to restrict their fluids, or you need to get rid of some fluids by making them pee. So it's very common in the hospital setting for you to write an order for I&Os, ins and outs, and daily weights. Remember from the WIT, he came in, the resident came in, or the fellow came in, and there at the end, pulled her chart and added up her outs, knowing that her urinary output had gone down to a small amount. She's in complete renal failure, she's going to die. And he said the end is near. So this is something you will keep up with anytime you have a hospitalized patient, whether it be in a surgery setting, internal medicine, pediatrics. You're going to measure these things. A careful history is important. When you're dealing with pediatrics, if I say that, if I bring my 3-year-old kid to you and say my kid's been vomiting for a week now and having diarrhea and not been eating, that should tell you there's going to be a fluid problem here. There's going to be a fluid problem. The physical exam, I'll go through several different physical exam signs that will tell you about the fluid status of a patient. And you need to practice. And then there are laboratory measurements that will get you to the point, or help you confirm what you've learned from your history and physical exam. All right, so here we go. Some of the things are systolic blood pressure. If your fluid volume is too low, your systolic pressure is going to go low. And that little kid that I gave you the example of just a few minutes ago, how old did I say he was? 3. His systolic pressure, his minimum systolic pressure at 3 years old should be 70 plus 2 times his age, 76. If his systolic blood pressure is not 76, he is in shock. The scenario I gave you about vomiting and diarrhea, he is in hypovolemic shock. His fluid status is out of whack. Orthostatic hypotension. If you come in and complain of dizziness, especially when I'm sitting down or I'm lying down and I get up and I get dizzy. The test for that is called a tilt test. You lie them down for about 5 minutes, you take their blood pressure. Then you sit them up and rapidly take their blood pressure again. And then you stand them up and rapidly take their blood pressure again. A drop in systolic or diastolic pressure of 15 millimeters of mercury is orthostatic hypotension. From supine to standing. And one of the primary culprits of this is volume. You're too dry. Measuring urine output, normally you're going to pee about 1 to 2 liters of fluid a day, normally. If you're in the hospital, if I have you in the hospital and you are unconscious, I have to provide you fluid, right? To maintain your basal metabolic rate. How do I know I'm providing enough? I know I'm providing enough because I'm maintaining urinary output like that was shown in WIP. Urinary output is your marker for giving them too much or too little or the right amount of fluid, intravascular. 24-hour urinary excretion of sodium will also contribute to this, although no one ever does that anymore, that test. You collect pee for 24 hours and then measure the sodium. Things that, if you're going to get admitted to this program, you've got to develop some bizarre sneeze, like some people do. Or rub liniments on you that smell like something that would put on a horse. There are illnesses that affect sodium. 2 of them in particular are diabetes insipidus and SIADH. SIADH. ADH, antidiuretic hormone, is a hormone that's produced by the posterior pituitary. It regulates the amount of urine you produce because there's a receptor in your pituitary that determines the osmolality of the blood. If it's too high, you're going to pee. If it's too low, you're not going to pee. I may have those reversed. I didn't think about it before I said it. But you know what I mean. Diabetes insipidus means that you don't have ADH, so you pee great volumes. Antidiuretic hormone. If you don't have antidiuretic hormone, you're gonna diurese. You're gonna pee like crazy. So you can measure whether, you can rule in or out whether or not you have SIADH, which is too much antidiuretic. Those people swell up because they have fluid overload. You can tell if you have SIADH or diabetes insipidus by doing a 24-hour, by measuring sodium over your 24 hours. Okay. Skin turgor. We talked about skin turgor back in anatomy. We know about tenting of the skin. Because your skin is hydrated, it snaps back in place. Doesn't work with infants or old folks, but in everybody in between it does. As a measure of fluid balance. Capillary refill, if I squeeze my fingernail and let it go, it should peak back up within 2 seconds. In a person who has decreased intravascular volume, like in a little kid, their capillary refill is going to be delayed. Breath sounds. Ordinarily, if I put my stethoscope on your chest, all I'm going to hear is in and out, breathing in and out. If you have fluid overload and you have infusion or pulmonary edema, I'm going to hear crackles. You know about crackles? Crackles is like if you take your hair and do like that, but beside your ear, that's what a crackle sounds like when you're breathing in and out. Okay? That means you have fluid overload. In that little kid I told you about, I'm going to get his systolic pressure has to be 76 or he's in hypovolemic shock. What I'm going to do is I'm going to give him volume. The formula for volume is 20 cc's per kilogram in a bolus. So I give him a bolus of fluids. How do I know whether or not I've achieved euvolemia? Euvolemia. Get his blood pressure. If it's not 76, I'm going to give him another bolus. However, before I do that, I'm going to listen to his lungs and make sure I'm not drowning him. I'm listening to his lungs, making sure there are no crackles. Makes sense, right? Okay. Mucous membranes. If you don't have enough fluid, your mucous membranes will be dry. In pediatrics, what you ask mom is, can you form tears? You can't form tears if you're too dry. So if the baby is sitting there crying their eyes out and there are no tears, and they have dry mucous membranes in their mouth, you're going to be thinking about a volume issue. And finally, the serum sodium, in your blood is something you're going to get. Too much volume, you have hyponatremia. Too little volume, you'll have hypernatremia because of concentration or dilution of the blood. Now, what determines the movement of fluid between the different spaces? These are the Starling forces of blood flow. You have really two categories, well, really three categories. One of them is the hydrostatic force. So if you see on the arterial side, the hydrostatic force is basically your systolic blood pressure. That's going to be driving fluid out of the vasculature system. On the other side, you have osmotic forces. You know what osmosis is, right? If you have a U-shaped thing with a semi-permeable membrane in the middle, you put sugar on this side, then the fluid on this side with no sugar is going to go down and move to the other side to try to equilibrate the two. And that's what happens in you. You have osmotic forces that drive fluid back into the capillaries, or back into the vasculature from the tissue side. You also have oncotic pressures. Oncotic pressures are derived from large dissolved substances in the blood. And the primary thing for driver for oncotic pressure is albumin. Albumin is like the just albumin. We'll stick with albumin right now. No, I'll explain. Albumin is like the sugar in the U. Normally, there's enough albumin, so the normal albumin level, which is 4 grams per deciliter, is in your blood. You have equilibrated that. If you don't have enough albumin because of liver failure, albumin made by the liver, if your albumin is 0.5, now you don't have enough oncotic pressure to pull fluid into the vessels. Now fluid goes the other way. Or it doesn't come in to start with, and you wind up with edema. Okay? Now, when you look at osmolality, and you remember from chemistry, osmolarity is the number of osmoles per liter. Osmolality is what we use because it's the number of osmoles per kilogram. U. The formula for that is 2 times the sodium. Because what is osmolality or osmolarity involved with? It's the number of dissolved particles, right? So 2 times the sodium plus blood sugar divided by 18, and the BUN, the blood urea nitrogen, divided by 2.8. So if you look at the normal osmolality of the blood, it's around 290 or so. This is 280. That's about 5. That's about 5. So the overwhelming majority of the osmolality of your blood is sodium. So sodium balance is critical to fluid balance. Where sodium goes in the body, water will go. Now, disturbances of fluid balance, if you have too little, it's hypovolemia, that's obvious. Hypovolemia represents a decrease in total body water. It's not intravascular, it's not extravascular, it's all of the compartments. That's dehydration. When you're out in the August sun all day long, you don't just deplete the fluid in your vascular space, you deplete it in the extracellular space and in the intracellular space. To replace it, you have to replace it in all 3 spaces. Too much water is the exact opposite. But with too much water, where is that too much water? If you have dependent edema, that's too much water, so what? You can't get your shoes on. If you have too much water in your lungs, you can't breathe. That's a more serious problem. As I mentioned earlier, euvolemia means you're just right, in terms of the fluid balance. It still may not be what you need, but it's normal for you. The dynamics of fluid balance, here we go. So we have heart failure up here. The heart failure is producing a low cardiac output. The normal ejection fraction of your heart is about 55–60% of the ventricular volume. If you have congestive heart failure, that's going to go down. If you have congestive heart failure as a result of myocardial infarction, so your myocardium is replaced with scar tissue, your ejection fractions will go down. I've seen ejection fractions 15, 10, 5%. This is heart failure. If you have a low ejection fraction, you're going to have a low blood pressure. If that happens, you're going to have a decrease in the amount of pressure and volume going through the renal arteries. Your kidneys are going to view that as a decrease in volume. Not a decrease in pressure, a decrease in volume. To correct it, the kidneys are going to try to get you volume by activating the renin-angiotensin system. You know the renin-angiotensin system? Everybody knows that by heart? Okay, well, you need to go get you some of that, okay? Decreased blood flow will increase renin production by the kidneys. Angiotensin 1 is converted to angiotensin 2 by angiotensin converting enzyme, which is stimulated here by renin. Angiotensin 2 causes the synthesis and release of aldosterone from the adrenal cortex. That causes the kidney to increase sodium reabsorption, decrease at the expense of potassium. So you're going to pee out potassium. And where sodium goes, so does water, resulting in an increase in volume and an increase in blood pressure, which now shuts off renin. Okay? So there's the renin-angiotensin system, sodium, water, blood volume, edema. Well, you can't take a picture of that. No, I'm kidding. Go ahead. Okay. Does that make sense? Well, wait a minute. You already got heart failure. Your heart's not pumping well enough. What do you think it's doing to the blood volume going through your lungs? It's backing up the blood volume in your lungs because your left heart's not pumping it out. And now you're adding more fluid or more blood volume. You're making this whole thing worse. The loss of pressure and ejection fraction is also going to produce the hydrostatic pressure because of the weight of blood that's not being pumped through the capillaries on the arterial side. So you're going to have an increase in that Starling force that's driving fluid out of the vasculature, and edema being produced that way as well. On the oncotic side, we've described this before. There are two things that we're showing here. One of them is, well, three. Malnutrition. If you don't eat protein, you're not going to make albumin. A person that's starving will not make albumin. We talked about the cirrhotic liver not making albumin. And also in patients with nephrotic or nephritic syndrome, they pee protein, they pee albumin. Their glomerular filtration is not, it allows you to pee protein. Nephrotic syndrome is a congenital problem. Nephritic syndrome occurs after a strep throat infection. Because you lose protein in either of those three circumstances, you have a decrease in the oncotic pressure. It says osmotic, but it's oncotic. Fluid stays out in the extravascular space or will move out there because of the semi-permeable membrane and the sugar in the U-shaped tube. Okay? You know, this could be really, really hard. But if you just stop and think about it for a minute, it's just fluid dynamics. What is the driving force? If you're asked a test question, that's the first question you should ask yourself. What's the driving force here? The driving force here is a decrease in cardiac output. What's the downstream sequelae of that? Well, I guess that's redundant. But what is the sequelae of that? And that's illustrated here. Okay. Do you need to take a break now, or we need to keep going? Keep going? Okay. All right. So, reasons for increased interstitial fluid. We're going to go through each of these separately. Increased osmotic pressure of the interstitial fluid. So, if you have excessive salt intake, or if there is retention of salt by the kidneys, as in the example, the renal system here. If you have a decrease in renal tubular excretion of sodium by decreased renal flow, like in the case of renal failure. Keep in mind, you're only going to get this if you have a functioning kidney. If you're in end-stage renal failure, you don't get this. That's why people in end-stage renal failure, this right here, normally you're going to lose potassium here. In end-stage renal failure, you don't excrete potassium, and they will be hyperkalemic. End-stage, that's just a common thread with end-stage renal failure. They are in hyperkalemia. Reduced renal perfusion, okay, that's renal, okay, same thing. Okay? Decreased oncotic pressure of plasma proteins, we talked about that. Enteropathy here would be some type of GI disorder like ulcerative colitis or Crohn's disease, an inflammatory bowel disease, or one of the different syndromes that don't allow you to digest food, or one of the surgical procedures, like a Whipple procedure for pancreatic cancer, where they remove part of your intestines as well as your pancreas. There used to be a thing called a Roux-en-Y, R-O-U-N, you have to know that, Roux-en-Y, a bariatric surgery, or Roux-en-Y, they reconnect all of your GI tract, and it would produce all sorts of fluid problems related to protein absorption. Malnutrition, just to say a word about malnutrition. In certain parts of particularly Africa, that's where you always see it, the little kids with the swollen belly, you know, it's called kwashiorkor. You're in jeopardy this weekend. Kwashiorkor. And what that is they've been breastfed, they've been getting their protein through mom. Mom's now pregnant with the next kid, so this kid is no longer getting protein. They're getting poor nutrition, if any nutrition at all. They wind up with no albumin. They wind up with bloating fluid. It's ascites. That's what it is. It's ascites, just like cirrhosis. So that's kwashiorkor, for an example here of nutrition-related edema. On the hydrostatic side, okay, so usually involves increased hydrostatic pressure on the venous side rather than the arterial side of the vascular bed. An example of that would be, what is the number one presenting, well, not number one. If I was going to say, what are the 3 presenting symptoms of a DVT? What would you tell me they would be? Swelling, since we're talking about edema, obviously swelling is it. Red. And pain. Right? So they come in with a unilaterally swollen leg. Why is it swollen? It's not because the veins are getting bigger. It's because the fluid can't get out through the venous system. Where is it going to go? Into the extracellular space, the extravascular space. It's going to leak out into the tissue, and you're going to have edema. Oh, there's where it says obstruction to blood flow right there. Lymphedema, the next one here, can be due to a whole host of things. We talked about in anatomy, removal of or disruption of the normal lymphatic channels. I was watching this show the other night. It was called like Pimple Zit Popper or something like that. Anybody ever know?
Dr. Pimple?
Yeah, that's what it was. That's what it was. It was on Viceland, which is a bizarre channel. I would encourage everyone to watch this show called Trixie and Caitlin, or Katie, or something like that. Trixie. There are these 2 guys. They're trans. They dress up as women. What is that? Trans. I don't know if drag queen now may be a derogatory term. I don't know if it is or not. Have you seen it? Has anybody seen this show?
No, but I went to a drag.
Oh, I know that, but I mean, you've got to watch the show. It's like Thursday night at 9 o'clock. It is the most bizarre freaking show. It is the funniest show. These two women are absolutely hilarious. They really are. What were we talking about? What were we this discussion all about? Oh, the pimple popper. Yeah. This black guy came in with this big mass on his back.
Yeah.
Did you see that?
Yeah.
And she got a 20 cc syringes and
How many did she end up?
like 30-something syringes. She drew this fluid out, and we'll talk about later whether it's a transudative or exudative fluid. But she drew 30-something 20 cc, that's 600 cc's off this guy's back. And where it came from was he had a congenital disruption of the normal lymphatic channels in the back of his neck and stuff. It was lymph fluid. And it was just the most bizarre thing. So.
We came back to see her like a month later or whatever, and it was partially back, wasn't it?
How would you fix it?
Well, they were going to do some type of I would think they probably have to put a shunt in there from that cavity into his chest or abdomen or something. But it was really impressive. Okay, so, all right, so there you go with Another one here, so the scarring would be like a mastectomy, also in radiation therapy. If you're radiating an area, you can describe the channels. Parasitic diseases, elephantiasis. Elephantiasis has a large, you see the pictures in Africa with the parasite. The reason they have swelling of their genitals and their legs is because they have a blockage of the lymphatic channels. For a bonus of 14 points, what is the organism that causes elephantiasis? Time's up. Okay. So you'll need to Google that. Okay. Any other questions about that? Uchera Bancroft. Right, so finally, permeability here. Inflammation causes, we know fluid can leak out of capillaries because of inflammatory processes. The wheel and flare, for example, that we talked about, it seems like 100 years ago now. Okay. All right, transudates and exudates. We've been over this before. You need to review this. Which one's a transudate, which one's an exudate? I'm not asking because it's written up there, but what causes the two? This is just basically fluid because it's going to have a low specific gravity. Specific gravity of distilled deionized water, remember, is 1.000. So this is merely water, a few dissolved substances. This is congestive heart failure, pulmonary effusion, pulmonary edema, edema in the pitting, edema of the lower extremities. This is a transudate. Okay. This is ascites from portal hypertension. And again, the enteropathies here. This will also include nephritic syndrome. Exudates, on the other hand, are inflammatory in origin. So this would be what you'd see in an infusion of the knee due to arthritis. It could also be due to malignancy. A lot of fluid. Amber's uncle recently passed away. He was healthy as a horse. All of a sudden, he winds up, can't breathe. He goes into the after-hours clinic. His lungs full of fluid. They wound up transferring. He tapped it. It's an exudate. It turns out it was malignant cells. So the ascites from ovarian cancer is as an exudate. Pitting edema, we talked about edema in the lower extremities, the dependent edema. If you have intact lymphatic channels and you have edema, and I push on you like that, and it leaves a dent, well, where the fluid went was into the lymphatic channels. That's why it was able to indent. You removed the fluid from the extravascular space and pushed it into the lymphatic channels. That produces pitting edema. Lymphedema, you have blocked lymphatic channels. When you push there, the fluid has no place to go, and it won't pit. Lymphedema does not pit. Common disorders associated with edema. Let's take a break here for a few minutes before we get into this, okay? Okay.
Huh?
Yeah.